Good morning, Horizons. How's it going? Hi. So my name is SALEENA SUBAIYA. I'm an assistant professor in the Department of Psychiatry at Columbia University. I'm a researcher and emergency medicine practitioner, and today I'm going to be talking to you about a study I've been leading, assessing syncretic ayahuasca practices, preliminary results from a multi-site naturalistic study of ayahuasca drinkers in non-tribal contexts. So for you who may not be familiar with the word, syncretic is the merging of several discrete traditions, especially those that pertain to religious or philosophical practices. No disclosures? So for most of you in this audience, you're already familiar with the psychoactive brew known as ayahuasca, which has been described by William Burroughs as the most powerful drug I have experienced. Yahe is not like anything else. It produces the most complete derangement of the senses. Ayahuasca has traditionally been used in the Amazon basin, socially and ceremonially as medicine. It is made of a combination of two plants, chacruna, or Psychotria viridis, which contains the serotonergic hallucinogen N,N-dimethyltryptamine, DMT, whose degradation is prevented by the use of the vine Banisteriopsis caapi, which contain alkaloids that function as reverse monoamine oxidase inhibitors. Ayahuasca use has expanded beyond indigenous communities, bringing us to where we are today. So there's been an explosion of circles globally, with an estimated hundreds of individuals sitting every night in New York City alone. Some headlines I'd like to highlight include one from The New Yorker, touting ayahuasca as the drug of choice for those embracing the wellness movement and kale. Two New York Times articles recognizing the use of ayahuasca among older populations despite its illegality, and the concerning and widespread rise of retreats over the last decade. Most recently, ayahuasca has been popularized after an NFL player, Aaron Rodgers, cited it as the reason for one of the best seasons of his life. So, reading these headlines and witnessing the rapid popularization of ayahuasca, as a medical researcher, I began to wonder its impact on behavioral health conditions. And I was curious to see, what does the current literature say? What I found was that it was challenging to find rigorous studies on the topic. In fact, only a handful have been published each year over the last 5 years. Those that have been published have small sample sizes with around 30 to 40 participants. Many of these studies also suffer from what's known as selection bias. That is, the population they are studying is not reflective of the population of people with behavioral health conditions that are consuming ayahuasca. And the vast majority of these studies have had loss to follow-up. So I'm going to walk you through a few of these studies and what their findings are and what we can safely conclude. And my hope is, as we embark on this talk, to instill in you the importance of being very thoughtful when interpreting research findings or reading research media headlines. Do not take anything, and that goes for my own research, without questioning, critiquing, and reading the fine print. So I'm going to start with one of the first randomized controlled trials of ayahuasca versus placebo on treatment-resistant depression. This was done in 29 participants, conducted in Brazil, and a very classic RCT, very controlled. And in this study, individuals were dosed with ayahuasca or placebo. And placebo was a concoction that simulated the taste of ayahuasca. It had some zinc to simulate GI upset. And they were left alone in a room with a playlist, and 2 clinicians were nearby should they need any help. So what does this graph show? It shows their performance on the MADRS, which is a clinically administered scale for depression. And basically, I've added some shading. So the green corresponds to mild depression, the yellow to moderate, and the red to severe. What you can see is that after the ayahuasca dosing session was depicted by the red line, there was a significant drop throughout the study period. There also was a drop, however, in the placebo group, which is noted by the green line. So what's interesting about this is the patient population in this study was predominantly female, from a low socioeconomic status, and 75% didn't complete a high school education. most participants were also living under significant psychosocial stressors. And during the trial, they were housed in a very comfortable environment. They were also giving meals. This may account for some of the effect sizes we witnessed here, especially that in the placebo group at day 1. Also, the sample size is quite small. And why is this relevant? So in a study looking at over 700 trials, those with a sample size less than 50, like this study, as compared to trials with sample sizes of 1,000 or more participants, smaller studies are likely to overestimate effect by 50%. Why is that? It's because these studies are more subject to publication bias. That is, positive findings are more likely to be published if your study is small. But if your study is big, it's more likely to be published regardless. So this more recent placebo-controlled trial of ayahuasca sought to investigate ceremonial context, that is set and setting. So what they did was they went to existing ayahuasca groups and they gave 30 participants, very experienced users, who've drank 24 or more times a freeze-dried pill with ayahuasca or placebo. And they didn't specifically recruit individuals with a behavioral health condition. Rather, they looked at various elements of psychopathology, of which depression is one. So the graph on the left explores a subscale of the DAS, which is a depression, anxiety, and stress scale. And this was given to participants before and the morning after dosing. What you can see here is the placebo group, interestingly, had a greater reduction in depressive symptoms than the ayahuasca group. This is curious. I mean, it may suggest that set and setting influenced this outcome. However, there are some issues that this study faced. For example, participants had low ego dissolution scores across the board, even in the ayahuasca group, with a significant ego dissolution experience associated with scores of 60% or higher. Looking further into this, it was ascertained that the ayahuasca pill had 50% less of the concentrations of DMT, harmaline, and harmine that would normally be expected in a dose. So all of these factors, in addition to the fact that you can see the ayahuasca group in the red bar had normal depression scores to begin with, can contribute to this large effect size that we're seeing in the placebo group. Finally, it's also worth considering how do experienced ayahuasca users react to being in ceremony and community that may provide comfort and support, as opposed to naive users with significant psychopathology or depressive symptoms. While these data may point to the idea that set and setting had an impact, I really don't know if we can say much about either ayahuasca or ceremony on this specific outcome. You guys still with me? Yeah? Okay, great. So I know it's a lot of data, so I appreciate you guys listening. So this is another study that was published in 2020, done in Spain, among a group of 40 naive users without psychopathology attending a retreat. And what this graph demonstrates is a moderate reduction in depression scores measured by the HAM-D, which is an interesting choice in scale because it's not meant for those who do not have depression. So what you can see is there was no difference the 1 month after ceremony. The error bars here overlap. But there was a significant difference in depression scores 6 months after ceremony. But they lost around 60% of people to follow-up. Consider if those individuals were in fact severely depressed. Would this effect size still exist? Also, it's interesting that this reduction wasn't there at 1 month, but it was there at 6 months. What if everyone engaged in psychotherapy, and what if they started an SSRI? This wasn't accounted for in the analysis. So again, really hard to interpret these data. So all of the studies we just reviewed were conducted outside of the US and for several reasons. Ayahuasca has been challenging to study here. It contains DMT, which is a Schedule I substance. To date, the NIH has not funded studies in this area, so academic centers are heavily reliant on private donor funding. Additionally, since it's brewed from plants and creating a consistent botanical medicine is challenging, there's little commercial interest in conducting clinical trials on ayahuasca. But there are several trials looking at sustained intravenous DMT and its combination with an MAOI inhibitor known as pharmahuasca. So in this landscape, we realized that getting any study off the ground in the US would present many challenges. So I decided to take a step back from ayahuasca and take a look at the experimental therapeutic model of research. So this diagram outlines this. How does a drug go from development, depicted in the orange? This is bench research, animal studies, preclinical models, and then it goes through phase 1 through 3 of trials, and that tests safety, efficacy, and finally lands you at the last stage, which is to see how drugs perform in widespread implementation. Because there's many biases that can happen with trials. It's a tightly controlled environment. There is very selective inclusion-exclusion criteria. And quite simply, there's this issue of pharmaceutical funding and publication bias. So for example, with SSRIs, 93% of published studies show an effect on depression. When unpublished studies are included, this drops to 50% of a positive effect finding. So the idea is that positive findings are more likely to be published in English journals. They're more likely to be published sooner, 6 years on average. So implementation science is this growing field of research, and it's critically important. Really what we're trying to see is how do drugs perform in the wild? What is their true benefit to society outside of the trial environment? So what I realized is we kind of skipped ahead with ayahuasca in the US. And in fact, in many ways, we're already at the end of the spectrum here, with hundreds of individuals sitting, as I mentioned, in New York City alone. So given my background in international public health and disaster medicine, working for the CDC, we would have to go into very, very challenging naturalistic settings and collect rigorous data. And so I wondered, could we do this here? So this brings me to our study objective. So the first is to better characterize syncretic ayahuasca practices in a global cohort, exploring things like prior ayahuasca use, retreat characteristics, and integration. We also wanted to evaluate the association between behavioral health conditions and the use of ayahuasca, focusing specifically on a cohort of individuals with depression and anxiety, not just all comers. I want to clarify that we did not set out to prove whether ayahuasca cures depression. This study design does not lend itself to those claims. However, rigorous cohorts can be a very useful step to beginning to explore these questions. So we designed a study intended to fill in some of the gaps and work within the constraints of the research environment. We sought to include a large sample size of 255 participants, and we decided to first recruit facilitators and retreat centers first. They would share our survey with a unique code to participants who had already committed to ceremony. We didn't really want anyone just taking it, online. We administer our surveys online 1 week before, 24 hours after, 1 month after, and 6 months after the last day of ceremony. We employed a fairly stringent inclusion and exclusion criteria. So we excluded individuals who used any psychoactive substance therapeutically in the last 3 months, or recreationally more than 3 times in the last 3 months, or at all in the last 1 month. We also stratified sampling. That means we included people with significant symptoms of depression and anxiety by making them take a screening survey. I'm going to now move on to our results, and I just want to say we're still actively recruiting. This data is preliminary, so put on your critical hat. So we have had 518 individuals take our screening survey, and based on our stringent inclusion and exclusion criteria, 334 were disqualified, mostly due to prior recreational or therapeutic substance use. From there, we have 147 who took our pre-ayahuasca survey. 124 completed our 24-hour, 117 completed our 1 month, and 51 completed our 6 month. And we've lost around 15 to follow up, with 6 still pending for the 6 month. We have some outstanding surveys due to active enrollment, so the numbers don't quite add up. So to date, we have recruited 17 circles around the world. We use a technique called snowball sampling, which uses the word of mouth to recruit circles. We advertise in forums such as Chacruna, the Brooklyn Psychedelic Society, and we wanted to include a broad mix of centers, from large retreat centers all the way to a mix of single practitioners throughout the globe. I was just told I'm running out of time, so I'm going to kind of fly through these. So the map represents where individuals sitting in ceremony reside. And what I think is really interesting about this map is we have no participants engaging in ceremony who reside in the Amazon basin. In fact, we only have one country represented from South America, Argentina, and one in Central America, Guatemala. So interestingly, circles in South Africa drew participants from Hong Kong, Namibia, and Ghana, and roughly 40% were from the US. So I'm just going to move quickly through this slide. Mean age was 39, 58% were female, 81% were white. The main reasons for seeking ceremony, of which participants were able to cite more than one, was mental health, overall wellness, and seeking help with trauma. This suggests that people with significant symptoms of mental illness, which was over half our sample, are seeking support through this modality. Other reasons include grief, to connect with loved ones, and addiction. So this slide reviews preparation and integration. Around 35% had a preparatory session. Many of them were asked to change their behavior, most did. Eliminating meat, abstaining from sexual activities, meditating, prayer, and changing their diet were all part of this. 86% debriefed after their ceremony, and only 30% engaged in integration, which was defined as psychedelic-focused therapy, any body work, meditation that was meant to process your experience since they enrolled in the study. So this slide describes some features. The y-axis is the number of participants. What you can see here is the majority were naive users. That's the bar graph on the left. And the average number of ceremonies that were attended during a single retreat were around 2 to 3. 46% had a person facilitating that was Placebo influenced, 7% non-denominational, 2% UDV or Santo Daime, and 22% just didn't know. So I'd like to clarify that this next analysis is preliminary and uncontrolled, and of the subgroup of individuals who had moderate symptoms of depression, not our entire sample. So the y-axis is scores on the BDI, the Beck Depression Inventory. Green corresponds to mild, yellow to moderate, and red to severe symptoms of depression. And the blue line is the average score of our participants as 1 week before, 24 hours after, and 1 month after ceremony. So what we saw was a drop of depressive symptoms after ceremony that persisted up to a month. This graph on the right is a subsample of severely depressed individuals. And what you can see here is they also had a sustained drop in symptoms 24 hours and 1 month after ceremony. So to compare this to a similar population, we looked at data of large randomized trials with SSRIs and SNRIs, and what was considered a clinically significant improvement, that is someone who says, I actually feel better, was around 35%, and that's depicted by the purple line if we anticipated a 35% drop. And what you can see is that our blue line is at least around there, if not better. Similarly, in the severely depressed group, what you would anticipate is even a larger reduction for someone to say, hey, I'm feeling better. That's around 46%. And again, our sample is doing as well, if not better. So this graph explores individual performances on the BDI. I'm going to actually, how am I doing? Good? Okay. So what this graph shows is individual performance. And so on the left, we have 1 week before ceremony to 24 hours after. So the average is the orange line. And what you can see is most individuals improved or stayed the same. The graph on the right is 1 week ceremony to 1 month, one week before ceremony to 1 month post. And again, the orange is the average score, and each line is an individual. So you can see that there are some people who did worsen. So this is not a cure-all for everyone, but for the most part, people improved. So some characteristics of our depression cohort. 19% actually didn't have, 19% had a formal diagnosis of depression. So the majority did not have a diagnosis. Only 3 individuals used antidepressants before ceremony, and 2 had discontinued these at the 1 month survey. No one started antidepressants in the 1 month after ceremony. Some other significant changes that they had was improved quality of life scores, actually a 17% increase in their quality of life before to 1 month after. And they also had improved psychological flexibility. And that measures the ability for someone to stay in the moment with negative thoughts or feelings and to change their behavior to goal-directed choices. So some strengths and limitations. So this is a cohort study. We did not have a placebo arm. There is this issue of expectancy bias. Individuals who are sitting for ceremony have heard the hype about ayahuasca, and that may lead them to anticipate symptom improvement. Also, they're also seeking treatment in a way. So selection bias is also an issue. These circles are not reflective of every single circle that is happening throughout the globe. We tried our best, but there's plenty of underground practitioners that we were not able to include. Also, we did not test ayahuasca for alkaloid concentrations, although we did have very high numbers of the mystical experience reported in our sample. So some strengths. We had a very rigorous methodology with minimal losses to follow-up, a global cohort, relatively large sample size of depressed individuals, and relatively few confounders. So conclusions. We had a white female predominance in our sample. Depressed individuals attend ayahuasca ceremonies seeking support with mental health, most without a formal diagnosis and most not on antidepressants. And we have evidence for a statistically significant association between ayahuasca ceremony attendance and improvement in depression scores. I did not say that ayahuasca cures depression. So what's next? We've translated our survey to Spanish. We're going to expand our recruitment and have a broader sample. We're going to analyze interviews we did with facilitators. So we interviewed many of the facilitators in our study, and we want to link their responses, like how long they've been training for, what their experiences are with our data. We're going to do a regression analysis, which accounts for confounders, things like how many times have you drank, are you engaged in therapy, are you engaged in mindfulness-based practices, and we're calling for multi-center randomized controlled trials on this in group and more controlled settings. And participant reflection should reflect the population of those with behavioral health conditions that are seeking ayahuasca, minimize loss to follow-up, and please, please, please publish your negative findings. And I'd like to acknowledge the following individuals. Thank you.
Just a little errata. I mentioned this as a joint presentation. That's a mistake in the program. These are two independent presentations, so I'm just going to announce the title of Kate's presentation is Ego Dissolution or Ego Tripping, Personality Profiles of Neo-Shamans. So this is considered a block of two presentations, but they are two independent authors and research. I want to know from Horizons if we're ready to have Kate up. All right, please welcome Kate.
Hi. It's good to see so many faces after what I hear was a pretty good night last night. I want to just start by thanking, acknowledging the traditional owners of the land and the Lape people, and thanking Kevin and the Horizons crew for putting this together. Okay, so my talk, Ego Dissolution or Ego Tripping, Personality Profiles of Neo-Shamans. Sorry, I'm just figuring out the tech here. Yeah, it's got this slide here, but this one's up.
Oh, it's because I think it shows your notes. So.
But see, that's the... Can we go back? I think it's showing the... the slide that's up is not what's on the screen for me. Yeah. This is the slide. Can you?
I can't see it. You can just go from click.
Okay, I think we've got it.
Okay.
Oh, no. All right, just bear with me. It's showing me the next slide versus what's up on the screen, so I'll do my best. Okay, so nothing to disclose for the presentation or for the research. And, oh. Okay, gonna have to go like this. So, what is a neo-shaman? I'm sure many of you have heard this term before. You know, over the last 100 years or so, shamanic rituals have moved from demonization, religious prohibition, to medicalization, scientific interest, to idealization, romanticization. The beliefs and techniques of neo-shamans incorporate a really diverse range of techniques and belief systems. And a somewhat alarming trend recent years has been the surge of what some researchers have called plastic neo-shamanism, or neo-shamanism. And this is a term that's applied to individuals who are attempting to pass themselves off as shamans, holy people, or other traditional spiritual leaders, but who have no genuine connection to the traditions or to the cultures that they claim to represent. You know, use of traditional medicines and new psychoactive substances is really expanding quite rapidly throughout the Western society. You know, locally, through psychedelic tourism. And this has also elicited increased media attention and reports of violations in these spaces, including sexual violence. So this is especially problematic considering the number of people who seek medicinal healing from past traumas, including sexual assaults. There are many resources geared towards participants to help them be informed and avoid some of these boundary breaches. Shakrina has a really good resource. It's called the Community Guide for the Awareness of Sexual Abuse. And you know, I started realizing that there's this focus on how we stay safe in these spaces, but less attention, especially academically, on who these neo-shamans are. You know, even in well-known Western psychedelic, you know, therapy institutions with guides, therapists who are bound by regulatory bodies and ethical mandates, we're still hearing reports of sexual assaults. So I have a background in forensics, criminal profiling, and I started to think deeply about why we need safety guides, why, you know, we're hearing all these reports, and why we don't really know why this gap exists around research into neo-shamans. Who are they? Who are the people behind the work? So, you know, who are these people, essentially, that are not necessarily bound by traditional practices, by community, that self-elect, you know, self-identify as a healer and build a community to serve, you know, either privately, academically, or commercially. And despite, you know, the expansive growth of New Age spirituality and scientific interest in altered states of consciousness, research of the neo-shamanic practice, journey, motivations, personality is lacking. It just has not been looked at. So I'm going to talk to you today about a survey that we did to try and get to the bottom of some of these questions. So far, we've only begun preliminary analyses, and I'm going to present some of that today. So, demographics. The people that took our survey, or at least answered the demographics section, were between 16 and 78 years old, predominantly male, most were married or living with a partner, majority white, probably to no one's great shock, and majority Hispanic, non-Hispanic, sorry. They were also very well educated. The majority had at least a bachelor's degree. And when we asked them what their typical professions were, there were more than 100 listed. Only 14% said that they were in a medical related or adjacent field, and only 9% who were counted in that 14 were therapists, counselors, or psychologists. When we asked them if they had any religion, they said predominantly they were spiritual, atheist, or other, which was universalist, pagan, and love for a number of people. They also had some psychiatric history and substance use. 35 said that they had a diagnosis of depression. 24 PTSD. 10 neo-shamans said that they were diagnosed with bipolar. 5 OCD, and 2 schizophrenia. All neo-shamans reported having used any substance in their lifetime, and that's including alcohol and tobacco. And 11 reported a diagnosed substance use disorder. What substances are they serving? Predominantly psilocybin, ayahuasca, LSD, and 5-MeO-DMT, among a range of other substances. And many of the neo-shamans reported serving more than just one substance. We asked them if they screened their participants before serving. Almost all of them said yeah, to some extent. But this ranged from Googling their participant that they think is going to sit with them, through to a physical exam and psychiatric history and 2-hour intake interviews. And this is probably representative of the diverse range of professions that we saw. We had construction workers, we had weed trimmers, we had artists, musicians, medical doctors, emergency medicine doctors, the whole gamut of professions. We also asked them if they'd ever had difficult experiences, or participants in their groups that had had difficult experiences, and many said, yeah, we have. One said, someone turned white. We were never really sure what happened, but the pulse was a little hard to find for a minute, but they were okay. Many said that they've had participants who've had panic attacks and severe anxiety. And we asked them, well, do you have a protocol for that? This is a kind of representative of many answers that we got, that there are many challenging experiences, but that they don't have protocols, or they don't change protocols based on what they expect might happen, because that sounds more like Western therapy or Western medical protocols than shamanism. And so this was reiterated in many forms, that every situation is unique and that they don't need protocols because that's a Western concept. Okay, so that was the demographics of our survey. I'm particularly interested in the personality of the people that self-elect to be shamans. So we included a bunch of personality assessments. We did the Big 5, which looks at neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness. And we looked at what's known as the dark triad, which is psychopathy, narcissism, Machiavellism. So what did we find? Well, on average, neo-shamans are pretty average. On 5 of the scales, they all scored just in the average range when compared against normative data sets. Probably also, to no one's great surprise, that was accepting openness to new experiences. Makes sense. So if they're, thank you, if they're average, my question was, well, are there bad apples? Are there people who are outliers who perhaps don't fit within that average range that maybe we should be wary of? And there were. Now, don't pay too much attention to this chart. I know it's a little bit hard to see. But we had a person who scored off the chart for neuroticism, which means that they could be sensitive, nervous, and subject to mood swings. In terms of extroversion, we also had someone who scored very highly. It means outgoing, energetic, assertive, but can also be excitable and attention-seeking. In terms of openness, we had people who scored very high and low. High score, creative, inventive, happy with abstract concepts, adventurous, but might be prone to unpredictable behavior. Low scores, you may be reliable, but closed-minded. Agreeableness. You might be had people who scored off the chart high. They might be cooperative and friendly, but submissive and avoid giving offense and allow others to take advantage of your trust. And low scorer, it means you could be analytical and competitive, but do not trust others and may be manipulative. And finally, conscientiousness. We also had extremely high, extremely low scorers. High score, well organized, but you might be inflexible. Low score, easygoing, but there's evidence that low scorers are also more hedonistic and interested in sex than high scorers. We also looked at narcissism. In terms of, this is all of the individual means on our narcissism scale. Neo-shamans had a mean of 0.26. This is lower than undergraduate students, so less narcissism than undergrad students. And a lot less narcissism than MBA students. But what about all of these outliers? High scores indicate thinking highly of oneself, needing admiration, believing others are inferior, and lacking empathy for others. And we had some people scoring pretty high. We also looked at Machiavellianism. Oh, how do we, oh, sorry, I think it's going the wrong way. Okay, sorry, we'll do psychopathy first. So the psychopathy checklist that we use looks at primary and secondary psychopathy. Now, on average, they scored pretty average. But we did have some people who scored, apologies, who scored pretty high, especially in secondary psychopathy. And people who score high on that scale are more likely to suffer from intense emotional arousal and psychological issues and be more prone to interpersonal aggression. In terms of Machiavellianism, again, neo-shamans have a mean of 1.99, much lower than the general population. But again, all these outliers. High scores mean you're likely to have a high level of deceitfulness and a cynical, unempathetic temperament. So what does this all mean? There's some emerging theories that break up narcissism in this space into two contexts. Spiritual narcissism, which is the belief that your spiritual wisdom makes you more special than others. It can be used to shield yourself from criticism, impress others, or enhance your self-esteem. And communal narcissism refers to grandiose, inflated perceptions within a communal environment. Communal narcissists often believe they have excellent social skills and high degrees of likability and helpfulness. Finally, there are some limitations to what we're doing. This preliminary data, as we said, we have further analyses to look at how these scales might interact with each other. But neo-shamans tend to, in many experience and also in the academic literature, engage in moral posturing. And this is to gain some advantage, an effort to have people like you or admire in some way. The neo-shamans are looking for authenticity and are potentially prone to fabricating responses to be seen as good. So that might influence the data set and might influence the way that they've responded. They might be overly choosing answers that put them in a good light, which might minimize our results. And other limitations are that 245 people entered the survey, but only 161 actually did the demographics. And of those, only 91 did the personality assessments. So who didn't finish the survey? Who are they? What's their personality? Are people who act badly in these spaces less likely to take a survey about how they act? Finally, I'm not here to dissuade anyone from sitting with neo-shamans, but I think it's important to be aware of the issues that belie this industry. Medically and psychiatrically vulnerable people seek out spaces held by neo-shamans. And so it's important to continue to look into and understand the practice and the people engaging in it. And thank you to everyone. My time's up. Thanks.